So today we're going to recognize the prevalence and natural history of pediatric non-alcoholic fatty liver disease, describe the screening guidelines, and then review the diagnosis and treatment. Next slide. So a brief overview about pediatric non-alcoholic fatty liver disease, or NAFLD. Next. NAFLD is actually an umbrella of disease. It includes non-alcoholic fatty liver, NASH or non-alcoholic steatohepatitis, which has inflammation and fibrosis, or NAFLD with fibrosis, or even cirrhosis. So you can kind of see there that the majority, 2/3 of patients have non-alcoholic fatty liver, but even as much as 10 to 15% have non-alcoholic steatohepatitis, where there's already more ongoing inflammation, or even up to cirrhosis. Next. The spectrum of pediatric fatty liver disease is kind of broad. This was looked at in the NASH Clinical Research Network that includes 176 children from 8 sites in the U.S. with their age 6 to 17 years of age. And you can see that 80% of these patients already had NASH at the time of biopsy. And 30% had stage 2 and stage 3 fibrosis, which is more significant fibrosis than one would expect. Their BMI percentiles were around 99th percentile, or a mean BMI of 33% with a range of 18 to 58. Remembering in pediatrics that the BMI ranges are not as helpful as the percentile is. Next. Some of the clinical features associated with more severe pediatric non-alcoholic steatohepatitis is increase in abdominal obesity or increased waist circumference. We kind of heard a little bit about insulin resistance. We see prediabetes or type 2 diabetes. Looking at race and ethnicity, Hispanics are more likely than white and then a lot more likely than black. There are some genetic components to it. Increasing in age in peri and postpubertal patients, and then increasing in liver enzymes, specifically the ALT of greater than 80. We also see it with some elevated triglycerides. Next. So what are the future implications for children with NASH? So we know that NASH-related cirrhosis in the U.S. alone has increased 6-fold over the last decade in adults. It's now the second leading cause for liver transplant in adults and may become the main leading cause for transplant. It's most rapidly growing indication for liver transplant related to hepatocellular carcinoma. So if we're looking at all this, we don't know what it means in children, but the trends in adults are concerning. Next. So let's look at the prevalence of pediatric non-alcoholic fatty liver disease. Next. So in looking at this, NAFLD is the most common cause of pediatric liver disease. We have clinics that are full of patients being evaluated or cared for with NAFLD. There are no studies describing the incidence of NAFLD in children. Next. But we do know it parallels the obesity epidemic that we're seeing. And so there's been a 2.7-fold increase in NAFLD from the 1980s to the current era because of the epidemic in obesity. Next. It does vary with age of the child, gender, race, ethnicity, and the BMI. There's an increase in prevalence in children with certain risk factors such as prediabetes, type 2 diabetes, obstructive sleep apnea, which you may get asked about, and then hypopituitarism. Next slide. It also depends on the population being screened when we look at the prevalence. Is it the general population or is it more the high-risk population? And what screening methods are we using to determine if kids have NAFLD? Next slide. So what we do know is that in the ages of 2 to 4 years of age, there's 0.7% prevalence in children of NAFLD. Now that's not that much, but by the teenage years, there's already a 17% prevalence. And if you're looking at, and that's general population, if you're looking at obese children and going by the ALT elevation or the liver labs, you're anywhere from 30 to 40% prevalence of NAFLD in pediatrics, which is very concerning. Next. In patients that are 11 to 22 years of age and Hispanic, there's a 4-fold increase. You can see there that Asian children have about a 10%, white children 8.6%, and then black children are more protected at 1.5%, but it is known that after puberty, they're more at risk for diabetes. Next, please. So children with type 2 diabetes had about a 50% prevalence of elevated ALT. Obstructive sleep apnea, like we said, was associated in 2 pediatric studies. And then children with hypopituitarism also have an increased risk, and even cirrhosis for those patients. Next. So kind of summarizing everything, the prevalence of pediatric NAFLD is paralleling the growing prevalence of obesity in children. The prevalence also varies with the population screen, the level of risk, and any modality that we use to detect it, whether it be labs or imaging. And it is higher in certain subpopulations, such as overweight, obese children. Males are more at risk than females, different ethnic groups, with Hispanics being the most at risk, and then patients that have prediabetes or type 2 diabetes, obstructive sleep apnea, or hypothalamic dysfunction. Next. Let's talk a little bit about the natural history. Next slide, please. So we're taking a retrospective look here. These are small studies, but one study was looking at 5 pediatric subjects based on liver biopsy with a follow-up of 41 plus or minus about 2 years, 41 months plus or minus 2 years. All 5 subjects had increased fibrosis on the repeat liver biopsy from a stage of 0.2 up to stage 2. So that's very concerning. If you look at the other study, we looked at 18 pediatric subjects with biopsy-proven non-alcoholic steatohepatitis. Remember, that has the more inflammation and plus or minus fibrosis. With 28 months follow-up, only about 40% had no change in fibrosis, but about 40% had progression in fibrosis, whereas only 15 to 20% had regression in fibrosis. So these aren't good outcomes for us. Next, please. Another look, we did the tonic trial, which is vitamin E versus metformin versus placebo, and this was a prospective look at it all. So there was about 47 kids in the placebo control that did nutrition and physical activity. And then if you look at the tonic control, looking at using vitamin E versus metformin, there was some histological improvements based on change in NAFLD activity score level, but the mean change in ALT was more impressive with a decrease in 35. And you can see there was some fibrosis improvement, some steatosis improvement, and then some inflammation improvement as well. Next, please. There is increased risk of mortality in pediatric non-alcoholic fatty liver disease. This study looked at 66 children with a mean follow-up of about 6 years. And it showed that 2 patients died and 2 patients required liver transplant. And so when you're looking at your observed versus expected, it was a significant change, letting us know that patients with fatty liver disease do have an increased risk of mortality. We've always known that. We've known that about the adults for a while, but in pediatrics, it's true as well. Next slide, please. This is another study looking at more adults, but it's got 229 adults with biopsy-proven non-alcoholic fatty liver disease compared to the regular population. And with NAFLD mortality, you had an increased overall mortality increase, cardiovascular risk increase, hepatocellular carcinoma increased risk, and infectious. Again, this is not good news for us in pediatrics. Next, please. There wasn't an increase in mortality in the study, but or in fibrosis, but fibrosis stage 3 and 4, irrespective of their activity score, had an increased mortality. So the scores of 5 to 8 did not have an increased mortality. I misspoke. Sorry about that. Next slide, please. So is there an aggressive phenotype for pediatric non-alcoholic fatty liver disease? We've kind of grouped it all together for a while, but we're starting to wonder who are the patients that may have a lot more aggressive that we need to be more try and identify them earlier. And this is looking at a study comparing severely obese adults versus adolescents at bariatric surgery. And you can see there that the adolescents, so there's 24 in each group, but the 63% of the adolescents had definitive NASH versus only 25% of the adults. Their activity score was higher. The adolescents had 83% of them had fibrosis, whereas only about 30% of the adults did. And their overall mean fibrosis score was higher. So this is concerning that there is a more aggressive phenotype in certain adolescents over adults. Next slide, please. So what we kind of know in all of this is that there's very limited data with small series. We're trying to extrapolate adult data to tell us about kids, but this may be insufficient. As we talked about, there may be a more aggressive version in pediatric NAFLD. We have early onset obesity in pediatrics, increased severity of obesity. And then the other thing that we don't talk about as much, but should be, is intrauterine exposure to maternal obesity and insulin resistance. We're starting to realize that your risk of fatty liver disease actually happens while mom is pregnant with the child. Next slide. Talking about the screening. Next, please. So we always talk about ALT, AST. What does this all mean? If you ever look at a lab report and you have a pediatric patient, we realize that the numbers they use there may be 40 or 50 for the upper limit of normal. These are actually determined by regional laboratories using local populations for norm. It does not exclude patients that are overweight or obese or those with liver disease. And so they just put together a group of patients to say, here's our norm. Well, looking at this from a pediatric perspective, we actually did looked at the National Haynes group, adolescent group of 12 to 17 years of age to determine what is actually normal for boys and girls. This excluded those that were overweight, obese, and those with underlying liver disease. And actually an ALT of 25 to 26 for boys and ALT of 22 for girls is what is considered normal. And these are those numbers that we use on the pediatric side. We don't actually go by what each individual hospital range says. Next, please. Now, we use ALT and AST, but there's a lot of limitations. ALT is well known that it doesn't correlate well with what the biopsy looks like. So if we take a biopsy based on the ALT, we can't tell you what we're going to see. As well as, excuse me, sorry about that. As well as some studies suggest that AST and GGT are better correlated with fibrosis. We've seen ALT changes even with placebo. So even when we don't make an intervention, we can see ALT changes. We also know that ALT fluctuates over time, and it can't differentiate between the non-alcoholic steatohepatitis with the inflammation and just plain out non-alcoholic fatty liver. Next. Next, please. Looking at ultrasound, we love ultrasound on pediatrics. It's non-invasive, it doesn't require sedation, and most kids can tolerate it. So it's very non-invasive. Some of the bad parts of it is not very sensitive or specific with low degrees of steatosis or fat in the liver. So we don't recommend it for screening in the NASH guidelines that came out in 2018. Ultrasound also can't differentiate between NASH and non-alcoholic fatty liver. Next, please. We're looking at some new advanced imaging techniques that are out. We've got some ultrasound-based techniques of shear wave and radiofrequency. There's MRI, different ones. However, in pediatrics, these are not widely available. And remember, we're talking about kids. So putting kids in an MRI scanner, they can't always tolerate that time, the noise, the closed space. And so having to do sedation to do these studies is not a good thing either. And so we're always trying to look at new ways for non-invasive testing, but also in the environment of the pediatric patient. Next, please. We do recommend that screening. All kids should be screened between the ages of 9 and 11. Children greater than the 95th percentile, for sure. Children between the 85th and 94th percentile with a BMI with other risk factors such as central adiposity, insulin resistance, prediabetes or dyslipidemia or sleep apnea, or even a family history of NAFLD or NASH. Next, please. Earlier screening may be considered in younger patients with risk factors like we talked about, such as severe obesity, family history, or hypopituitarism. And you may even consider screening of siblings and parents and children with NAFLD if they have known risk factors. So there are times that I diagnose a child with non-alcoholic fatty liver disease, and I suggest to the parent that, based on what you're telling me with your own risk factors, you should go be evaluated. It's not always the parent, and then we diagnose the child. Next, please. Currently, our best option is ALT, but we know it has limitations. We do use the 22 for girls and 26 for boys for cutoff. If it's persistently elevated for more than 3 months or twice the upper limit of normal, we think kids should be evaluated for non-alcoholic fatty liver disease, And if there's an ALT of greater than 80, this is increased concern and what makes it more of an urgent workup for us. Next. We do not recommend ultrasound like we talked about as a screening test. Your child may get an ultrasound to rule out other things, but we usually don't use it as a screening test for non-alcoholic fatty liver disease. We do recommend follow-up screening if one is not diagnosed, so repeating the ALT every 2 to 3 years if risk factors remain unchanged, or considering repeating screening sooner if clinical risk factors of NAFLD are increased. Next, please. So diagnosing it. Next, please. It is a diagnosis of exclusion. This is looking at a lot of different diseases that we rule out when we see elevated liver enzymes. Next. We use a combination of the lab tests, imaging modalities, and sometimes we do have to use a liver biopsy as that's our gold standard. Next, please. This is just kind of looking at what a biopsy looks like and what we're looking at under the microscope. And you can see here, the big thing to take away is that there is a pediatric pattern, which is different than what you see in the adult pattern on a liver biopsy when we see NASH and NAFLD. Next, please. Liver biopsy is mainly used to quantify steatosis. Steatosis or fat in more than 5% of the liver cells is abnormal. And so that's where we look at the NAFLD activity score. Doing this with imaging can sometimes be helpful, but imaging, as we talked about, availability is not ideal at this point. Next, please. It's hard to distinguish NAFLD from NASH when you have obesity based on obesity severity or your metabolic dysregulation or even your blood work. NASH is more common in those with an ALT greater than 80, but it's not a slam dunk. And those with panhypopituitarism or type 2 diabetes have more association with NASH. We talked about liver biopsy as our gold standard, and there's certain requirements that we like on that biopsy so we can diagnose it. Next, please. Liver biopsy considerations is something that we take as very important. We have to get a liver biopsy in a pediatric patient. We have to use anesthesia, and so we don't take it lightly, but it is very safe in children, even if they are overweight. We sometimes will use our radiologist in certain situations, but it is considered safe. Deciding the optimal timing of biopsy is important to work with at the family decision, and then it can help us diagnose not only NAFLD, but it can help with diagnosing other liver disease or ruling out other liver diseases. Next, please. This is more looking at the presence of fibrosis and kind of what we look at. Again, it tells us that those with an ALT greater than 80 predicts advanced fibrosis more. Next slide. So we've talked a lot about benefits and limitations, but each thing that we can do, each diagnostic approach, whether it be labs, imaging, or biopsy, have their benefits and their limitations. Unfortunately, as of now, liver biopsy is still our gold standard. It also allows us to rule out other diseases, and we don't have any great markers, non-invasive markers at this time, but hopefully in the future. Next, please. Again, imaging, we're trying to determine fibrosis. We still don't have a good thing for this. We're doing further validation and studies are required. Next slide. So recommendations for diagnosing, we're trying to exclude other liver diseases when evaluating a patient with suspected NAFLD. We do consider liver biopsy in children at risk for NASH and or advanced fibrosis. We do not recommend ultrasound to determine or quantify the steatosis, and CT is not recommended to determine steatosis due to exposure and radiation. Next slide, please. Last thing we'll talk about is treatment. Next, please. The goals of treatment are pretty simple. We would love to have regression of the non-alcoholic fatty liver disease defined as decreasing the steatosis, the inflammation, or fibrosis. We would love to have resolution of NASH, which is determined by liver histology. As you can tell, both of these would require repeat liver biopsy. Next slide. Liver histology and our assessment of that is looking at the change in fibrosis or scar tissue over time as a reasonable treatment outcome in children over longer periods of time. But we don't love doing a lot of repeat liver biopsies. Next slide, please. We look at the ALT. If there's a decrease in ALT, we think that's overall associated with improvements in NAFLD, but again, we don't know what's meaningful. Next slide, please. Ultrasound's not reliable, as we talked about. MRI is promising, but we need more validations and we need more available. Next slide, please. So we have to go to some other treatment goals too. We're looking at decreasing their central fat adiposity. We're looking at improving their dyslipidemia, their hypertriglyceridemia, their insulin resistance, and blood pressure. So now we're looking at other markers outside of the liver. Next slide. Our biggest thing we focus on is lifestyle and dietary supplements. That's why you're hearing from those specialists, because they're extremely helpful. There are some medications, but they're not as readily available on the pediatric side as they are in adults. And in rare cases, or extreme cases, I should say, not rare, we use surgery. Next slide, please. Lifestyle modifications are still our number one. We work to improve diet and increase physical activity. This is the main thing that we work on in pediatrics and children, and that's, you'll hear a little bit about from Leslie as well, but we really try and get them active and adjust their diet when they're young and teach them healthy habits at the young age. Next slide. We try and avoid sugar-sweetened beverages. You've already heard a lot about that. Well-balanced diet, vigorous exercise, and limiting screen time. That is the hardest thing in this day and age, is limiting the screen time. Next slide. We don't currently have any available recommendations on peds. There are studies going on. As I talked about, surgery may be an option for selected individuals in severe cases. It's not our go-to, but we are using it some in peds. Next.